Alright everyone, our lecture today is going to be over small intestine and appendix disorders. And I kind of lumped these two together because the small intestine doesn't have too much and the appendix is a pretty short and sweet lecture. So I tried to put together a nice solid group of things that we could discuss together. And here's just a couple of, I love little cartoons and emojis, just kind of help me get in the mood of studying. And I love the Awkward Yeti. If you've never checked out Awkward Yeti, you should definitely check it out. Here are our instructional objectives to guide you through this lecture. And here's our topic outline. As far as the small intestine, we're going to cover several things: small bowel obstruction, paralytic ileus, celiac disease, lactose intolerance, and then we're also going to throw in a nut allergy. I know that's kind of an outlier, but we do need to kind of briefly mention that. And then we're going to be covering the appendix, and namely appendicitis. So starting off, we're going to talk about small bowel obstructions. And bowel obstructions in general, you can kind of lump them all together, although small bowel obstructions are 80% of cases of mechanical intestinal obstruction, meaning that they are the majority. Only about 25% of cases, so maybe 75% small bowel, maybe 25% large bowel, which we will discuss more briefly a little later. But let's talk about small bowel obstructions first. Essentially, an obstruction, just like we talked about in the esophagus, is any type of blockage from the normal flow of intraluminal contents, which are digested food particles leading up to fecal material. And when this is interrupted, it is not a good thing. And there are essentially kind of two different types of small bowel obstructions. It's one, a mechanical small bowel obstruction, or it can be a functional obstruction, meaning that there's not something that's obstructing it physically, but the peristalsis is dysfunctional, therefore you have an obstruction that way. And that's what we term as more of an adynamic or paralytic ileus, which we'll talk about later as well. So for right now, we're going to be discussing small bowel obstruction in regard to mechanical small bowel obstructions. Okay? So developed countries like the US, adhesions from surgery, from prior surgery, are the most common causes. And other causes include hernias, malignancies, other infections, and inflammatory disorders. Now, small bowel obstructions can be functional, right? So that's what we talked about, more like a dysfunctional peristalsis, like a paralytic ileus, or mechanical. And like we said, we're going to talk about mechanical right now. And they can also be acute versus chronic. And you can have a partial obstruction or a complete obstruction. Those are kind of the different ways we classify obstructions. There's three main points of differentiation to consider in small bowel obstruction. So like we said, partial versus complete. Now, a partial obstruction, if you can imagine, let me see if I can, get my drawing tool out. A partial obstruction is going to be where if you have a gut, let's say this is a gut, there's a nice wall here. All right. A partial obstruction means that you have it where there is some sort of inflammation or blockage, but you still have a little bit of means for things to pass through. So that's partial. And a complete obstruction is going to be the intestinal lumen is completely blocked off, and this is not going to get through. So this starts getting big, filled with fluid and air, and becoming distended and discomfort. So that's essentially the difference between partial and complete obstruction. Patients with complete obstruction, occasionally they'll be able to pass a little bit of gas or stool because they have that residual gas or stool within the distal colon. But essentially, with a complete obstruction, you will get total obstipation or complete blockage, no stool, no gas, no nothing. closed loop versus open loop obstruction. So with a closed loop obstruction, the lumen is occluded at 2 points, kind of like a hernia. So if you can imagine, let's say you have a ring here, and you have bowel coming in here, and it's actually coming through this ring and then coming back out like that. It's getting obstructed kind of in two areas, here and here, and this loop here is closed off. That is a closed loop obstruction, and these closed loop obstructions are much more commonly compromised, so the blood supply getting cut off and requiring emergency surgery. So I tend to think of that as like femoral hernias and things like that. And then another thing to consider when we talk about mechanical small bowel obstructions are whether the small bowel obstruction is proximal or more close to the stomach or more close to the colon. Okay, so distal obstruction causes more distension and less vomiting. A proximal bowel segment causes a little less distension but more vomiting. So it can be anywhere in the pathway of the small bowel. Those are some little things to consider when we're thinking about small bowel obstructions. Adhesions from previous abdominal surgery, we said that is the most common cause in adults of small bowel obstruction. And adhesions are these little areas of scarring that kind of pull different pieces, kind of pulling things together that aren't supposed to be pulled together, and you can get blockage. You can see that here. This right here is actually that closed loop. That's what I was drawing earlier. Maybe this drawing is better than the one that I did, but this is a closed loop. You can see how the blood supply can get cut off to this section, thus causing necrosis and sepsis. That's an incarcerated hernia. Incarcerated means it's trapped and it can't be reduced. And we'll cover hernias in a separate lecture, but just keep in mind that it is a common cause of small bowel obstructions. Other things that are a little less common but still cause obstructions: malignancy, intussusception, which is when the bowel telescopes on itself, which is shown in this picture here. And it's more common like in young babies and toddlers. Crohn's disease can cause problems from mouth to anus. So pretty much anywhere you see GI problems, Crohn's disease could be one of the culprits. And then there's other things that can cause small bowel obstructions. For the most part in vignettes, from what I've seen, I tend to see these two that pop up for small bowel obstructions. Some of the most important risk factors for developing SBO, similar to the etiologies, would be prior abdominal surgery, right, causes adhesions, abdominal wall or groin hernia, which is the second most common cause, Crohn's disease, like inflammation, increased risk for neoplasm, prior abdominal pelvic radiation, and foreign body ingestion. So you can see that the risk factors tie into the etiologies. Just to be clear, I named several of the more common etiologies, but if you look on UpToDate, I mean, there are just so many causes of bowel obstructions. And by no means do I expect you to know all of these by heart, but you'll see that a lot of them we kind of hit at least every now and then. Like adhesions, we said most common. It tells you what the independent risk factors are for adhesions. It tells you about hernias and risk factors, volvulus and risk factors, and so on. I don't expect you to memorize this entire chart, but it is worth your while to kind of read through it once and become familiar with it. So how do patients present? Well, you have a blocked part of your small bowel, and so you can imagine that with the buildup of air and contents, you get this abrupt onset of kind of this colicky, crampy abdominal pain. And it's usually intermittent, or it kind of fluctuates, but if it is continuous and severe, strangulation may be present. Also, we said the more proximal small bowel obstructions tend to have pretty consistent nausea with vomiting. And depending on where the obstruction is, the vomiting can even be feculent, which is poopy vomit, which is just disgusting to think about, but it can be. One other major symptom would be obstipation. So obstipation is this guy right here. That's what I think of when I think of obstipation. It's thou shalt not pass. You have complete obstruction. You're going to have an absence of stool and flatus. So no farting, no pooping. Sounds great, doesn't it? Then another thing that you see, especially on physical exam and observation, is abdominal distension. Like we mentioned before, proximal obstruction tends to have more frequent vomiting, severe pain, and less or minimal abdominal distension. And distal obstruction, less frequent vomiting, more significant abdominal distension. On physical exam, you should include evaluation for systemic signs of dehydration, sepsis, abdominal inspection, auscultation, percussion, palpation, as well as a digital rectal exam. And I'll take a minute here to stress that anytime you have a patient with abdominal pelvic presentation, no matter what it is, you should consider doing a digital rectal exam and a fecal occult blood test. Just mentioning that. Okay, especially patients that are surgical candidates. It's just routine. With small bowel obstructions, because of the intestinal distension and all the vomiting and the loss of fluids and decreased absorption, dehydration tends to set in pretty quickly, and it can be one of the key and hallmark features of small bowel obstruction. And because of this persistent vomiting, fluid loss tends to lead to hypochloremia, hypokalemia, and even metabolic alkalosis. So you do have to be wary of that. Of course, when you're looking at the physical exam, vitals are going to be your first thing that you look for. And on vital signs, you'll tend to see manifestations such as tachycardia, hypotension, tachypnea, and then even altered mental status and oliguria, or a decreased urination. Inspection, you're going to want to look with your eyes first. It's the first thing you do when you walk in the room, and you're going to want to notice if the patient is distended. Now, don't assume that a big abdomen means that they have a distension. Talk to the patient. They know what their normal abdomen looks like, and they're usually able to tell you, like, hey, man, my stomach doesn't normally look this bloated. It looks super bloated. Or they can't button their pants, or they can only wear stretchies, something like that. Auscultation, the classic auscultation for an SBO is this high-pitched tinkling noise. It's like a tinkle, 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 and then a rush. It tends to what you hear, and they can be slightly hyperactive with this tinkle and rush. And then if you have significant distension, the bowel sounds can even become muffled. And then as the progression happens and the bowel becomes more sluggish and even necrosed, it can become hypoactive. That's a more later stage SBO. Palpation, you're gonna want to feel for any type of mass, hernia, tenderness, and then digital rectal, really just kind of feeling for fecal impaction, any distal mass, and then evidence of blood. Like we said before, you have to be on your toes when it comes to small bowel obstruction. The vast majority of these are fairly benign, and even some of them can be managed non-surgically, but you always have to kind of be on your toes looking for those signs of incarceration or strangulation of the bowel, because this can lead to shock, gangrene, peritonitis, perforation, and sepsis and death. Okay, so we do have to make that diagnosis. What we're looking for in this are signs of more systemic disease, so fever, severe continuous pain, throwing up blood in the stool, shock, gas in the bowel, or portal vein, abdominal free air, which would be indicative of a small bowel rupture, peritoneal signs, and then of course acidosis. So when we're doing the diagnosis evaluation of a small bowel obstructions, most of the time they're going to be in the emergency room. If they're not in the emergency room, if you suspect that they're in your office, I suppose that you could get the workup started with some plain films and basic lab work, but eventually these patients are going to get moved to the emergency room and be admitted to the hospital. Now, laboratory studies, we tend to get the typical labs for the patients with abdominal pain, and that generally includes CBC with differential, CMP or a BMP with liver enzymes, lipase, a urinalysis, and a pregnancy test. And I'm pretty liberal with my pregnancy tests. I don't tend to trust my patients. I know that sounds awful, but you don't want to miss an ectopic pregnancy, or you don't want to do radiation on a patient that's pregnant. It's pretty standard to get pregnancy tests. Usually patients anywhere from age 11, 12, all the way up to 55 to 60, depending on whether they've started their period in the younger age group or they've reached menopause in the older group. And then anywhere in between, if someone has had a total hysterectomy, I don't get pregnancy on that. Remember, you're always considering the systemic signs of illness, and if they do show, a little fever, hypotension, or rebound tenderness on exam, or excessive vomiting, you're going to want to consider adding an ABG looking for acid-base status, and a serum lactate, which is looking for bowel ischemia and sepsis. Although there are many ways to diagnose small bowel obstruction, the most common and efficient way is to get first an acute abdomen series, which is plain film x-rays, followed by a CT abdomen pelvis with contrast if it's not contraindicated. And this is straight from the current textbook, because I know there is some matter of personal preference as far as what is the best initial radiologic exam to get for small bowel obstruction. In my experience in the emergency room, we tend to start with plain films. And when we get the plain films, we get the acute abdomen series, which includes a one-view chest, an upright and supine abdomen. And what we're looking for are the telltale signs of SBO, which are dilated loops of small bowel, full of air, and then air fluid levels. And they're going to be proximal to the point of obstruction. And then you're going to have minimal gas throughout the colon, right, if you have a complete small bowel obstruction. And some of the x-rays that you see are pretty telltale. And I'll show you some of the things that I look for on the next slide. Now, CT abdomen pelvis is way more useful than plain radiographs. And we almost always follow up the plain film with the CT, because not only does it help identify the specific transition point or the specific exact point where the bowel is obstructed, it also guides the surgeon to know if they're going to have to do a surgical repair. Then they'll know exactly where to go. It also tells us the severity of the obstruction, and it identifies any other lesions, masses, hernias, things that can be the etiology of the obstruction. It also helps you identify complications like ischemia, necrosis, and perforation. So CT just all around better. The recommendations that I found said that as far as if you suspect that the patient has a full-blown complete obstruction, that it's really not necessary to use oral contrast, because the patient's not going to be able to tolerate very well. It's going to be uncomfortable for them and delay care. So you should try with IV contrast only if they can tolerate it. But if you suspect a partial obstruction, oral and IV contrast is going to be superior, and that's what we want to do. If, again, they have signs of bowel compromise like perforation, necrosis, ischemia, like on exam you feel generalized guarding, rebound tenderness, you might get the surgeon on board sooner rather than later. And sometimes you can even, if the patient's severely unstable, you can forego everything and go straight to the OR with these patients. So here's some other radiologic images. As you can notice, they're plain films that are showing dilated loops of small bowel with air fluid levels. So you can see these bowels are pretty markedly distended and have a lot of air within them. And you can also see these flat lines. See one here, 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 here. This is an air fluid level. So air, remember, rises, fluid, gravity brings fluid down. And so this is areas in the bowel that are full of air and fluid because it can't get past a certain point where the obstruction is. And so that's what you tend to see on an x-ray. And here's another one, maybe less distension, but I always tend to think they look like kind of clouds in the sky. When I think of clouds, they kind of look like that. And whenever I see that, that is not normal in the bowel to have these air fluid levels. All right. And another thing is that it usually ends at a certain point. Like you don't see a lot of air or fluid in the colon, right? You just see it up in the small bowel, and that's also an indicator. One other way that they tend to describe the X-ray findings of small bowel obstruction are these string of pearls sign. So if you think of like a necklace, like some bling here, and you have these little pearls on it, that's another way to describe it. These are little gas bubbles in the abdomen representing small pockets of gas that are trapped between the little areas of the small bowel, and it's pretty much diagnostic of a small bowel obstruction. So treatment, how do we treat these patients? Well, patients diagnosed with acute small bowel obstruction should be admitted to the hospital, and they're going to need the evaluation of a surgeon. So you're going to need to consult a surgeon and admit to the hospital. Now, not every patient that has a small bowel obstruction requires surgery. There are patients that do well with the non-operative management. And this is appropriate if the bowel obstruction is incomplete, or if there's no signs or symptoms, fever, tachycardia, peritoneal signs, or leukocytosis. And if we do whether or not we do a non-operative management, we're going to want to treat the patient with IV fluids, either lactate or ringers or normal saline, and that's to get their hydration status up. Remember, a lot of these patients are dehydrated. You will also tend to have to add potassium because they tend to lose a lot of potassium from the fluid loss, and it corrects the hypokalemia, which is typically present. When you have the small bowel obstruction, you have to mark the patient as NPO or no pros, so nothing by mouth, and that helps limit the further bowel distension and discomfort. And these patients also get NG tubes, so you get a nasogastric tube, put it down into the stomach, and that helps decompress some of that air, the distension that occurs because of the obstruction. Patients also tend to be placed on empiric antibiotics to help limit the amount of patients that develop infection or problems with the obstruction itself. And then for those that are treated non-operatively, another medication or treatment that can be used to help stimulate the passage or the unblockage of the bowel would be administering gastrografin. So gastrografin is like what they use in contrast for like CTs and stuff. And for patients with non-operative small bowel obstruction that have like maybe adhesions or things that are causing it, you give this hypertonic water-soluble contrast, and what it does is it draws fluid into the bowel, and it decreases the wall edema, and it stimulates peristalsis to try to get the bowel moving again to clear that obstruction. Now, surgery is indicated for complete obstructions, for partial obstructions that are persistent and are associated with constant pain, or if you suspect strangulation. Okay, and most of the time these are done as means of exploratory laparotomy. And while they're in there, they tend to kind of lyse the adhesions if they notice that that's the cause, resect any necrotic bowel, and get the patient back on their feet. Now, here are some of the indications for immediate surgery. Bowel compromise. If patients are suspected of having a bowel compromise, like ischemia, necrosis, perforation, and this is based on clinical radiologic examination, they need to go to the OR, and this is stat. And clinical signs and symptoms, like we mentioned before, are going to be not just colicky abdominal pain and a little bit of vomiting. It's going to be fever, leukocytosis, tachycardia, continuous abdominal pain out of proportion to exam, metabolic acidosis, tachypnea, peritonitis, and even SIRS. Remember, that's precursor to sepsis, right? it is difficult to predict ischemia based on clinical parameters. There's a study that they did that pretty much showed that physical exam and clinical assessment of these patients is not always accurate. So the study showed that even experienced clinicians were wrong in their preoperative assessment more than half the time in patients, and they eventually were found to have gangrenous bowel. So my advice to you, especially as a young clinician, would be to always, I wouldn't say cover your butt, but I would say be conservative, like really think about the ramifications of your decisions and always do what's best for the patient. And a lot of times what can be done, I mean, in these cases, the majority of the time, I mean, it's the surgeon's call whether or not the operation is done. And us as PAs, we can help surgeons, but we're not the primary surgeon. So a lot of this decision making doesn't fall on our shoulders, which is nice. You want to also use, if you have the opportunity, use radiologic imaging to guide your decision making. So like I mentioned before, I love algorithms, and so this is a nice little concise algorithm of everything we've just talked about, talking about what the initial management is, the things we talked about, NPO, electrolyte repletion, fluid resuscitation, NG tube, CT, and surgical consultation. All right, and then this is trying to help you or the surgeon decide whether or not they require surgery based on all of the findings here. If it's yes, surgery. If it's not, is it adhesive small bowel obstruction? Well, and then you keep going down, and it tells you kind of how to administer the gastrographin and all of the rest of the monitoring that goes along with it. Now, I rarely see questions in PANCE preparation question banks about large bowel obstructions, but it is on your PANCE blueprint, and I do want to spend at least one slide's worth of discussion on it because I think it's important just to be familiar with it. So approximately 25% of intestinal obstructions are in the large bowel. Remember, we said the other 75 to 80% are going to be in the small bowel. So by far, small bowel obstructions are more common. Over 75% of large bowel obstructions can occur usually distal to the transverse colon, and this is where the size of the colonic lumen is smaller. But it's also good to know that the most common location of obstructing colorectal cancer is in the sigmoid colon. And the causes of large bowel obstructions are similar to small bowel obstruction, but as you can see here, the vast majority of these, 60% or more, are caused by colon cancers. So that is in contrast to small bowel obstructions, where adhesions are the most common. Adhesions are still a cause of large bowel obstruction, but much less likely than small bowel. Also, hernias and volvulus are causes of large bowel obstructions. How do these patients present? Well, it results in less fluid and electrolyte disorders than small bowel obstruction, but it still causes bloating, abdominal pain, and obstipation, plus or minus, that's supposed to be a plus or minus nausea and vomiting. A lot of times, since the blockage is a lot lower down, the nausea and vomiting is not as persistent, but it can happen. And then patients tend to get the same kind of colicky, crampy abdominal pain. Diagnosis is made similarly, plain films, CT exam, and management. All these patients get admitted to the hospital, and most of them require surgery. 75% ultimately requires surgery and the same hospital admission. So again, you're going to admit them to the hospital, fluid resuscitation, monitoring, and emergent surgical consultation. And they can be pretty striking on x-ray. One of the ways to tell the difference between a large bowel obstruction and a small bowel obstruction is anatomically. So I don't know if you noticed in the small bowel obstruction, you saw these kind of rings that were like within the bowel that were kind of circumferential. So if you have the bowel kind of like this, you saw with the air fluid levels and things, you saw the little markings that kind of go all the way around. So that's in the small bowel. In the large bowel, you have these they're more like just little indentions or little divots that you see. Like this. And like this. So you get like these little indentions, but you never get it where it goes all the way around like that. That's the difference. You can see here how striking those images are. Still get some air fluid levels too. All right, so remember we said that as far as obstructions, there are really two major types of obstruction. One that we just talked about was more of a mechanical obstruction, something physically blocking the lumen of the gut. And then we said there was another major cause of obstruction where you have this decreased peristalsis, whether it's decreased or absent, and this is called paralytic or adynamic ileus. And the most common causes for this are going to be patients in a postoperative state. Now, remember we said for mechanical small bowel obstructions that having adhesions from surgery were the most common cause, right? Well, that's remote surgery, right? Because it has to have happened long enough ago that adhesions can have developed, right? So this is not like I had surgery a few days ago, a few weeks ago, a month or two ago. This is like 6 months and longer, right? So that enough time that for those adhesions to start forming. Now, paralytic or adynamic ileus, the causes are post-operative state. This is immediately or soon after, within the same admission after abdominal surgery. Other things that can cause it are going to be medications like narcotics that tend to slow down the gut, and then certain spinal cord injuries, shock, metabolic disorders, and peritonitis. And the clinical presentation, as similar to small bowel obstruction, so a lot of times it's hard to differentiate between a small bowel obstruction and a paralytic ileus because they're both technically obstructions. You're essentially going to get distension. The patient experiences a lot of the same symptoms, so colicky abdominal pain, plus or minus vomiting, nausea, a significant amount of bloating and discomfort. The abdominal plain film that we tend to get first, it shows a uniform distribution of gas in the small bowel and the colon and the rectum, right? Because there's no complete obstruction. It's just the gut's kind of sleepy. It just doesn't move things like it's supposed to, but it's not physically obstructed. And so there's no point of obstruction like there is with a mechanical obstruction. And, with abdominal surgery in general, because of the trauma and the movement within the surgery that takes place, the gut kind of tends to take a while to kind of wake back up after that. So there is a degree of normal post-operative adynamic ileus. It's usually several hours. Usually the patients can't be discharged home after abdominal surgery until they start passing gas and until those guts start waking back up. But in this case, this is delayed recovery from surgery. So there's several days of inability to pass gas, or significant distension or paralysis after surgery. The treatment, it's mainly supportive, okay? It's not surgical because there's nothing to take out. It's just trying to wake that gut back up. And the way that we wake that gut back up is, continuing to give the patient IV fluids, keeping the bowel happy and not stressing it out more than it needs to be. So keeping the NPO, resting the bowel by not giving the patient anything to eat or drink. In the meantime, you're correcting any electrolyte abnormalities. You can use NG tube suction if needed. And then you're going to want to do on these patients kind of these serial abdominal examinations, making sure that the gut does start waking up. Like I said, surgery is really not usually needed, and it should resolve with time or addressed medically, right? Taking away the medication or whatever that caused the issue to begin with. A lot of questions on tests, they love to compare and contrast small bowel obstruction and paralytic ileus. So Up to Date had a really nice little chart here, kind of comparing the two, which I think you should definitely commit to memory. This is one of those money charts. And before we touch on that, you can see here, this is a an image, an X-ray image, you can see this global distension. So this shows, this gaseous dilation of the colon and the small bowel, and it's in a uniform pattern. There's no point of transition, right? So this is a paralytic ileus, not a mechanical obstruction. So here we go. Let's tackle this little chart here. So the way it's set up is, here's the signs or symptoms, and then it talks about whether they are present or not in the ileus and a small bowel obstruction. So abdominal distension, you're going to have it in both, right? That's kind of one of the hallmark findings of obstruction in ileus. Now with bowel sounds, with an ileus, they're usually more silent or absent, whereas initially for the small bowel obstruction, you hear these high-pitched tinkles, right? As far as obstipation, they're both going to have obstipation. They're both going to have trouble passing gas and stool. Pain, well, pain is subjective, so it's hard to quantify, but if you had to compare the two, usually ileus tends to be more mild and diffuse, whereas small bowel tends to be more moderate to severe and colicky. Peritoneal signs should be absent in ileus because this is not a mechanical obstruction. There's no risk for severe strangulation, whereas small bowel can have that. Radiographically, we mentioned that it's going to be global dilated loops throughout the entire small and large bowel, whereas small bowel obstruction, you're going to have dilated loops with air fluid levels, and there's going to be some specific point or absence of colonic gas. Okay. Again, fever and tachycardia, these are signs and symptoms of necrosis or perforation. They should be absent in the ileus. And if you see that in someone you suspect to have a small bowel obstruction, that should raise your suspicion that something more is going on. Last but not least, vomiting. You can have vomiting in either one. And don't forget that because of the obstruction happens past the duodenal area where bile is secreted into the small bowel. If the blockage is past that point, the bile has nowhere to go, so you can actually get bilious vomiting with a small bowel obstruction. All right, we finished small bowel obstruction. So we have been talking for about 35 minutes or so. If you think that you need to take a quick break, now would be a good opportunity. If not, let's just keep going. So next we're going to talk about celiac disease. And I think you guys are learning about celiac disease at the right time, because it is a disease that maybe 10, 15, 20 years ago was not as well known as it is now. Now everywhere you go, you take a trip to H-E-B, to Walmart, gluten-free is everywhere, even in, mainstream stores, fast food joints, everywhere. It's a buzzword, it's a buzz kind of thing, it's a trend that things have gluten-free options. I've even seen gluten-free cupcakes and cakes and bakeries and things. So there's a lot more awareness of celiac disease. It classically or historically was called sprue or celiac sprue, and it can also be referred to as gluten enteropathy. So what happens in celiac disease is it's a permanent dietary disorder. It has immunologic, kind of an autoimmune property to it, where the patient has a response to gluten. Gluten is a part found in grains, and it results in damage to the proximal small intestine mucosa with malabsorption of nutrients. So hypersensitivity to gluten, and that's found in most wheat products, and it's autoimmune. And symptoms can manifest, any time. It can start as soon as you start giving a baby, weaning them off of strictly milk and putting them on like cereals and things. They can start having symptoms, and sometimes even cases get missed in pediatric, in childhood, and aren't diagnosed till late childhood or early adulthood. So you can find the diagnosis at any time during that process. One of the main things about celiac disease is you have to consider it. It has a lot of really vague, kind of sprinkled little symptoms here and there. So it can be quite challenging to put your finger on the diagnosis if you're not looking for it. So always consider celiac disease in patients that are having some of the signs and symptoms we're going to discuss in a little bit. And it is still, even though there's more awareness of it, it is still underdiagnosed in the adult population. Now, if you're like me, I'm not super keen to knowing what certain foods are. I'm not real aware dietetically. So I put down here where gluten is found, and it's found in wheats, barleys, rye, and oats. And I don't know about y'all, but when I was little, my mom used to sing this little song called, it was Oats, Peas, Beans, and Barley Grow. But in this case, because we're talking about gluten, you can kind of change that little nursery rhyme around to say oats, rye, wheats, and barley grow. And that's how I remember which foods trigger or have this gluten in them. Another thing, just kind of, I was curious because this word sprue, I was like, what is this word? So I looked it up, and historically it is a disease of, usually in this it's called tropical sprue, but it's of an unknown cause, characterized by fatty diarrhea and malabsorption of nutrients. So back in the day when we couldn't quite differentiate this from just the regular old topical sprue, we just called it sprue. But now that we know kind of exactly what's causing it, it has a better name, a celiac disease or celiac sprue. So it's more common in women, and there is a component of family history with first-degree relatives. Like we mentioned before, it can present anytime from infancy, when like cereals are introduced, all the way to elderly. And the peak presentation is going to be in infancy and old age. Clinical presentation, so symptoms of malabsorption. So what is malabsorption? So all throughout your stomach, especially in your small intestine, your duodenum, is where a lot of the nutrients are absorbed from the food that we eat. And when you have the term malabsorption, it's a blanket term. Celiac disease is not the only disease of malabsorption, but malabsorption means you're not absorbing the vitamins, nutrients, fats, things from the food that you're digesting. And so because of this, diarrhea is a very common symptom, because your gut essentially your body's attacking your small intestine. It's decreasing the amount of surface area that the small intestine has to absorb these nutrients and fats. And because you're not digesting a lot of them, they're going kind of straight through, and they're causing this diarrhea, namely steatorrhea. Steatorrhea is fat-containing stool. It tends to be really, really malodorous and oily. So patients come in and they tell you, like, my diarrhea, I have a lot of diarrhea. Ask them what it looks like. Ask them what it looks like to them, and a lot of times say, well, I don't know, but it's just, I can see these little oil droplets within it, and it smells really bad. I've never heard a patient come in to say that their stool smelled really good, but this is exceptionally foul smelling. Patients also have, because of the malabsorption, they have weight loss. They have failure to thrive, and children have failure to thrive. They have small status, they don't grow. They also can get a lot of bloating and discomfort, especially after eating a gluten-filled meal, because they can't absorb it. They get weakness, fatigue, anemia, and a lot of vitamin deficiencies, especially fat soluble vitamins, D and K especially. Yep. Approximately 40% of patients with a positive serologic testing are consistent with disease. So we'll talk about serologic testing here in a sec. Some of them have no symptoms at all, which is kind of mind-blowing, right? That you can have this disease and not even know that you have it. But that's just a little side note. On physical exam, it can be normal in mild cases. Most of the time what you're going to be seeing on physical exam are signs and symptoms of malabsorption. Loss of muscle mass, subcutaneous fat. They'll be pale due to the anemia, easy bruising because of vitamin K deficiency, hyperkeratosis because of the high vitamin A deficiency. A, D, E, and K, remember, those are the fat-soluble vitamins. Because you're not digesting fats well, then you're not absorbing these vitamins very well either. And you can also get vitamin B12 deficiencies and things like that too. The abdominal exam, sometimes you'll have some mild distension with hyperactive bowel sounds. And then there's one specific dermatologic manifestation that tends to pop up a lot on exams. And not necessarily your physical exam clinically, but on like your pants. And that is this dermatitis herpetiformis. And it is not part of the herpes family, but it's herpes-like, herpetiformis, meaning that you see these kind of blister-like lesions that appear on the skin. A lot of times they tend to appear like on the extensor surfaces, so the elbows and shin area. The thing to note though, just because a patient doesn't have this skin manifestation doesn't mean that they don't have celiac sprue, because only about 10 to 20% of patients with celiac disease actually have this dermatitis herpetiformis. And I've seen it before in the GI clinic, and it can be easily misdiagnosed as eczema or some other atopic type rash. So it's good to put those pieces together. And like I said, on exams, they love to add this little tidbit in there to help clue you into what the patient has. For diagnosis, you're going to want to always start with serologic markers in these patients. And when I worked in my GI clinic, we kind of had a batch order of serologic markers that we would do on all of our patients we suspected of celiac disease. It included the TTG IgA, the anti-gliadin, the IgA EMA, and there's others that I don't mention here, but there's a kind of a spectrum of different markers, serologic markers that we test for. Now, TTG IgA is the most sensitive and specifically type 2. And that is the one that really tells you if they have it or not, and then plus or minus a lot of the other things that we look for. And patients, it's something to note that a lot of times patients, since there's widespread awareness of celiac, a lot of these patients kind of self-eliminate gluten before they go for testing, especially if you mention to them that that's what it could be. So you want to tell your patients if you're going to be sending them for serologic testing, blood testing, then you want to tell them to eat the normal diet, what they had been eating before, because if they eliminate the gluten before testing, you might not get accurate results. After you look at these serologic markers, if they show signs of celiac disease or if they're inconclusive, the next step is to do an EGD. And the EGD is going to be with mucosal biopsy. You're going to want to take samples from the proximal and distal duodenum, and this will help confirm the diagnosis. And what we tend to see on endoscopy, as you can see here, this is a normal, small intestine. Here you can see the scalloping, where you get these little scalloping or atrophy of the duodenal folds. And then microscopically you see villus atrophy. So the villi are these little finger-like projections that increase surface area in the small bowel for absorbing nutrients. You can see here that over time the body, in the autoimmune process, kind of attacking itself, it wears down those villi, get atrophy, and that decreases surface area for absorption and causes inflammation in that area. And so that's what you tend to see both actually when you're doing the test, and then you're going to send those biopsies off, and then that's what they're looking for. The pathologist is looking for these telltale signs of celiac disease. At the same time, you're going to want to check, because you're expecting this malabsorption process, so you'll want to check vitamin levels. You'll also do an anemia workup, and you'll see that these symptoms, these problems, including the endoscopy, if you have to repeat it, which it's not always necessary, you should see improvement with a gluten-free diet. Now, there are some algorithms, one for children and one for adults, on the diagnostic approach, how to approach it. I think this is a little bit too deep for our purposes. I think if you're familiar with the different serologic markers and understand that you recognize it in history and physical exam, you order the serologies and then you confirm with the endoscopy. That's essentially what we do. Okay, and then gluten-free diet. And it's not just gluten-free diet. There's a lot to. I mean, if you can imagine having to modify your diet from the time you get up in the morning to the time you go to sleep, it really does change the lifestyle of a lot of these patients. And as a general rule, there's 6 key elements to managing patients with celiac disease, and they're listed here in the acronym Celiac. So if you see that. So the C would stand for consultation with the skilled dietitian. A lot of times, I know when I worked in my GI clinic, we had 15 to 20 minute appointment slots for patients. And that's certainly not enough time to have a long conversation with patients about what to eat and what not to eat, and how to read like a nutritional label and stuff. So this is the type of patient that you should definitely refer them and their parent, if they're a kid, refer them to a dietitian so they can have a sit down. And it's a lot of instruction that has to take place, a lot of education about the disease as well. And this one's most important, a lifelong adherence to a gluten-free diet. Like I said, nowadays it's actually a lot easier because a lot of product packaging has gluten-free on it as kind of a buy me tactic. And a lot of restaurants also have gluten-free options. So it's getting better for this group of individuals. The I is going to be identifying and treatment of nutritional deficiencies. So remember, even though we put them on the gluten-free diet, sometimes we still have residual nutritional deficiencies, iron, folate supplements. We have to continue. This can be kind of hard for patients. They can feel isolated, especially kids and parents. And so a lot of these kids, families, have advocacy groups or kind of support groups that can help them kind of work through this lifelong disease that they're going to have to deal with. And then last but not least, a continuous long-term follow-up. These patients are following up in your office, depending on how well they do, every 3 to 6 months they're going to be in your office, making sure that everything's going the way it's supposed to. Last but not least, prognosis. So nowadays, patients with celiac disease, they have a pretty normal life expectancy. The 2 main things I want to mention here as far as risk factors or associated increased risk are going to be an increased risk of lymphoma and an increased risk of carcinoma in both the small and large bowel. So you do have an increased risk of those 2 things, and that's about the extent that I want you to know about prognosis. Moving on to lactose intolerance. So I don't know about y'all, but I had to drink a lot of milk as a kid, and babies, they live on milk, right? So as babies are small, we have a lot of lactase, a lot of the enzyme to break down milk. And as we grow older, some of us unfortunate people have a large drop off of the lactase, and thus developed what is called lactose intolerance or lactase deficiency. And it is a lot of people. Approximately 50 million people in the United States have partial to complete lactose intolerance. I am one of those people. You can see here who are the affected population. So 90% of Asian Americans have lactose intolerance. 70% of African Americans, 95% of Native Americans, 50% of Mexican Americans, that's me, 60% of Jewish Americans are lactose intolerant. And as far as Caucasians tend to be about 25%. And I did a little research on that. It's thought that some of the more affluent Caucasian individuals, had more access to cows and milk. And so they tended to have to continue to break that down over their lifespan rather than just as a baby. I don't know. Maybe that's the reason. I'm not sure. Either way, it is what it is. You can also get lactose intolerance that arises kind of secondarily from other things like Crohn's disease and celiac and certain infections. Patients have great variability in their clinical symptoms. So some patients just get a little bloated. Some patients have severe gas. Some patients get pain, So because it is so nonspecific, there's this tendency, it can go both ways. So there's a tendency for both lactose intolerant and lactose tolerant individuals to mistakenly attribute a variety of abdominal symptoms to lactose intolerance. Let's read that again. Some lactose intolerant and lactose tolerant individuals mistakenly attribute a variety of abdominal symptoms to lactose intolerance because it's so nonspecific. Most patients, even with lactose intolerance, can drink at least one serving of milk a day. It's like one glass of milk. And most of the time they can do that without having abnormal symptoms. But some patients have complete lactose intolerance where they can't drink even a glass of milk in a day. Most mild to moderate amounts of lactose malabsorption patients experience bloating, abdominal cramping, and a lot of gas, a lot of flatulence. And with higher lactose ingestions, like say a whole tub of ice cream, they might get an osmotic diarrhea as well. And isolated lactase deficiency does not result in other signs of malabsorption or weight loss, in contrast to like celiac disease. Diagnosis. So most of the time in clinical practice, clinicians just tell patients that they suspect of having lactose intolerance, they tell them, do a trial of lactose free. Keep a food log and don't eat anything or drink anything with dairy for 2 weeks and see how your symptoms do. I mean, if there's a resolution of symptoms, complete resolution, that's suggestive of lactase deficiency, right? If you have a mild case and you can kind of isolate it this way, you have a reliable patient, then you don't have to do any specific testing for it. However, if the results of your little lactose-free trial are inconclusive or the patient has severe symptoms, the most widely available test for the diagnosis of lactase deficiency is a hydrogen breath study or breath test, not urea, hydrogen breath test. Awesome. Oops, I didn't mean to click that. All right. So what can we do? What can we do if you have lactose intolerance? We said it was pretty common, right? So the goal of treatment in patients is achieving comfort, right? So you don't want patients to never, ever get to experience, things with milk in it. That's a lot of things that have milk: ice cream, cheese, milk, and nowadays we don't have to completely eliminate it from the diet. Most patients can kind of comfortably, once they know that they have lactose intolerance, they can kind of find their threshold, kind of how much can I push it kind of thing. Foods that are high in lactose, like milk, ice cream, cottage cheese. Other types of cheeses have lower lactose content. And then there's also yogurt that contains bacteria that has lactase in it, and those are well tolerated. Nowadays, there are different substitutes, especially like this lactate or lactose-free milk that tastes really good. I sometimes get it because it has a better shelf life. And they have over-the-counter Lactaid, which are these lactase enzyme replacements, right? So patients that know they're about to eat an ice cream, they don't want to hold out on the ice cream, they can pop a little caplet, and it helps improve absorption and eliminate the symptoms. For those for those patients that do decide, I'm just going to stay away from dairy to begin with, they do have an increased risk of osteoporosis. So you'll want to mention to them that if that's their kind of plan of action, that they do supplement with calcium. All right, moving on. We're going to cover nut allergy really briefly. I know in your immunology module you did cover some food allergies and type 1 hypersensitivity reactions. So we're just going to cover this really briefly. So nut allergy includes peanuts, tree nuts, and seed allergies, and they're one of the most common food allergies out there. There's some evidence of increasing prevalence in certain countries, especially those with the highest rates of food allergy. We have a lot of people in the United States that do have a nut allergy. And I read a study not too long ago that showed that there are certain countries that introduce nuts to babies a lot earlier. Nowadays, I believe that they recommend not introducing any type of peanut butter or peanuts until the age of 2. But in these other countries, they start introducing it, before the patient even turns 1. And in those countries, the rates of peanut allergy are a lot lower. So it's just interesting. I thought it was kind of interesting. Most allergic reactions are immunoglobulin or IgE mediated. And they can, range from mild symptoms, like a little bit of itchiness in the throat or a little bit of urticaria, all the way up to severe anaphylaxis. And nut allergies tend to be pretty significant. I know there are some patients that even just smelling peanuts can have anaphylactic reactions, which is not good because there's a lot of products out there that contain nuts. Now remember that with sensitization, these IgE-mediated allergies can develop through primary sensitization to the food or through secondary via cross-reactive allergens like birch pollens and things. Risk factors, family or personal history of atopic disease. So if you have generalized allergies, tend to have higher risk of developing nut allergy, severe atopic dermatitis, egg allergy, and then a family history of peanut allergies. And then, like I mentioned before, early exposure helps lower the risk of allergy. If you have exposure by at least 4 months of age, it shows kind of this ability to lower the risk. So I know the pediatric recommendations are always changing. And the last time I checked, it was 2 years of age when you start introducing it. But I know there is evidence to start introducing nuts at a younger age now. So IgE-mediated food allergic reactions, characteristic stuff, urticaria, angioedema, respiratory, GI, cardio, and it's usually pretty quickly after eating or being exposed to the allergen in the nut. You have to get the clinical history, and these patients, from a young age, usually kids that have the initial reaction, they know that they have it. The parents know that they have it, and it can be quite difficult for these families because they have to continuously remind other people, including teachers, coaches, babysitters, everyone pretty much, that their kid has a significant nut allergy. Think about it. Serve peanuts on airplanes, right? So you have to be prepared for this, and knowing that child is not always going to be within your, in your vicinity. Your kids go to school, kids go to daycare. You have to be able to instruct your patients and parents well enough to be able to then have them know what to do in a situation, know how to use an EpiPen, know how to instruct then their secondary caretakers of the child. So it seems pretty simple, right? You just avoid the nuts, but it's nuts are in everything, and there's a lot of hidden places that can be detrimental to kids. The way that we diagnose it, We can do skin prick tests or other blood tests to establish a diagnosis. And I mean, the most straightforward approach in any food allergy is complete avoidance, but like we said, it can be challenging. Patients and parents should be counseled on diet, reading food labels, looking for allergens, and patients should always have EpiPens and should be instructed on how and when to use it. All right, last but not least, we have acute appendicitis. Now, if you've never heard of acute appendicitis, I think you've maybe been living under a rock, because I think everyone at some point has at least heard of acute appendicitis, whether on TV or a family member, a friend, or even yourself that's had appendicitis. It is inflammation of the appendix, and it is the most common abdominal surgical emergency. Okay, epidemiology wise, 8.6% of males, 6.9% of females have lifetime risk, so it is slightly more common in males. The most common ages of presentation are going to be between ages 10 and 30. I tend to think of it as like teenage, early 20s kind of presentation is when I see it most. But it can be in any age group. It can be from infants all the way to elderly. So you have to always have it on your brain in your differential. Usually how it's initiated is this obstruction of the appendix, and that can be by fecalith, which is kind of liths is like stone, and fecal is poop, so it's like this little poop stone that blocks the appendix. You can also get it blocked with inflammation, foreign body, like a seed, or lymphoid tissue or neoplasm. And what happens is it increases the pressure within there. You get venous congestion, infection, and if untreated, that can swell, become very inflamed, painful, and eventually perforate. It can be sometimes a little difficult to diagnose. Not every patient reads the textbook, like I like to say. So there are several atypical presentation, especially in the very young and the very old. And then sometimes patients just take a while to come in. They take a while to get into to see you. So at that point, that can definitely complicate things. I love this. So acute appendix, one of my favorite things. It's just funny. Remember the right lower quadrant, and we're going to talk about that in a second. And then here's a CT showing the appendix inflamed. We just talked about this. We said the lumen of the appendix tends to be obstructed, and that's how things start. Something obstructs it, then it becomes swollen and distended, and you get periappendiceal fat stranding and inflammation, and then eventually can perforate. Let's see. Like we said, teens to mid-20s. Prognosis is worse in infants and elderly patients. They have a higher rate of perforation. Symptoms: abdominal pain, definitely the most classic. Abdominal pain, and classically, both clinically and textbook wise, the classic presentation is this the initial periumbilical / epigastric type pain, so more centralized, vague pain, and then within a matter of hours to a 24 hours, it migrates from that central area down and shifts down into the right lower quadrant and then stays there. It's generally kind of the steady ache, and it's worsened by moving, walking, coughing because of the inflammation of the peritoneum around the appendix. Now, as the appendix starts distending and you start getting more peritoneal inflammation, it can lead to more sharp, consistent pain. And most of these patients, in addition to abdominal pain, also have anorexia. And now this is not like the I don't want to eat because I want to be skinny anorexia. This is anorexia, meaning they are not hungry. They do not feel like eating. If you have a patient that comes in and they are chomping down hot Cheetos and they have right lower quadrant pain, it is not likely acute appendicitis. Nausea and vomiting are typically present, even if it's just a few episodes. But the nausea and vomiting typically follow the pain. So the pain initiates first and then the nausea and vomiting. Patients also tend to have this kind of low-grade fever. If you have a patient with really high-grade fever, it could be something else, or it could be some sort of perforation of the appendix. Signs, so tenderness in the right lower quadrant, maximally at McBurney's point, which is 2/3 the distance from the umbilicus to the right ASIS. And if you need a kind of a diagram of what that is, so here's the trunk, the abdomen, here's the umbilicus, and then you have your little, your hip bones, right? They have this ASIS on each side, your hip bones. This is your ASIS. So from your umbilicus to here, it would be either 2/3 from here to there, or 1/3 from here to here. So it's right about there. So this is 1/3, and this is 2/3. I don't know that that's really that important, but that's McBurney's point right here. And that is the point where they tend to have the maximum amount of pain, tenderness. And other things that patients have, rebound tenderness. So rebound tenderness, when you push in, usually try to push away from the pain, push in gently and release it quickly. And that causes pain in the right lower quadrant. And patients also have voluntary and involuntary guarding, where they kind of make their abdomen rigid when you try to examine it to protect from pain. They also can have diminished bowel sounds, although that's not always necessary. We already talked about fever. And then you have these 3 special exams. Rovsing sign is when you palpate deep in the left lower quadrant and it causes referred pain in the right lower quadrant. So the way I think of Rovsing sign, let's draw this torso again, right? So draw the torso. Here's the umbilicus. Okay. What I think of when I think of Rovsing, to me it sounds kind of like rover. So I think of a person, and what they're doing is they are throwing the bone over to the dog. Rover. Right? That's how I think of it. This is the dog Rover in the right lower quadrant. So the owner is in the left lower quadrant throwing the bone to Rover. And that is Rovsing sign. I know that's dumb. That's how I remember it. The other 2 tests are the psoas sign. So the psoas, or iliopsoas, is a muscle. It's a muscle that helps us flex our thigh at the hip. And what we see here is a right lower quadrant pain when the patient lies on the left side and extends the right leg, the right thigh. And I don't know if you can kind of picture that in your head. And usually psoas sign is associated with a retrocecal appendix. So anatomically speaking, you have your colon, your ascending, your descending, and your transverse colon, and then you have the cecum here, which is the terminal ileum, and then the small bowel, blah blah blah, right? So this is your cecum. It's kind of like the first part of your large intestine, and then the appendix comes off of the cecum at some point. There's many different orientations of the appendix, but one of which is retrocecal. So behind, if you kind of transparently see it behind here, retrocecal, so behind the cecum. And those can be more challenging because the appendix doesn't touch the kind of the anterior abdomen. It kind of goes posteriorly. So these patients can sometimes present a little less classically. So anyways, you can do a psoas test to help you determine retrocecal appendicitis. One other test is the obturator test. Obturator are muscles within the pelvis, And what you have the patient do is flex the right thigh and internally rotate when the patient's laying flat on the bed, and that will elicit pain. That's another way to assess for acute appendicitis. All these tests are great, but what I tend to do is, especially in little kids, because little kids tend to guard you, whatever you do, because they're scared. You're there, they think you're going to poke them, and they're just uncomfortable in general, so it's hard to get an accurate exam on them. One of the ways I do it is you can either do kind of a pinch test, where you kind of just pinch an inch on their abdomen and kind of let it go, and when you let it go, if it's ow, that shouldn't cause pain. And then other thing is jumping jacks or jumping. Usually have the patient kind of stand up by the side of the bed and jump. If a kid can jump a couple times, 3, 4, 5 times, they don't have appendicitis, right? The peritonitis from appendicitis makes you want to lay completely still. Walking, coughing, just gently hitting their bed, where they're laying, it causes a significant amount of pain. So if you can't get a good test on a kid, just have them stand up and jump and see if they can do it. Diagnosis, they say classically in the textbooks that acute appendicitis is a clinical diagnosis. In our day and age, with the advanced imaging and things that we have, it tends to be a diagnosis through imaging. I will tell you that, because I like to talk about street med in addition to book med. Although, historically and technically, it can be a clinical diagnosis, right? Laboratory findings, do not hang your hat on laboratory findings. They're helpful. They can help you be more confident in your diagnosis, but you shouldn't hang your hat on a positive or negative result. So most of the time, these patients tend to have moderate leukocytosis with neutrophilia. So leukocytosis with the left shift. Some patients can also have some microscopic hematuria and pyuria. If you have just a little bit of hematuria and pyuria, it can be appendicitis. If you have gross hematuria or significant amount of bacteria or white blood cells in your urine, it's probably a UTI, not appendicitis. And then you always want to get a pregnancy test in females, right? If you have an ectopic pregnancy, it's different than acute appendicitis, although pregnant ladies can get appendicitis too, and it can be a little bit more challenging to diagnose. Imaging studies are extremely helpful in diagnosis. Most surgeons won't operate unless they have imaging evidence, unless you have kind of an old school surgeon that is willing to come examine the patient and use their clinical diagnosis to take the patient to the OR. So CT scan, a CT of the abdomen and pelvis with contrast is the best imaging study. Has it's probably even higher. It says here 94 to 95% sensitive and specific, but it's really good at finding appendicitis. It's definitely the most accurate test. Ultrasound is less accurate. Obviously, it has less radiation than CT scan. CT scan has quite a bit of radiation, although ultrasound is very user dependent. So whoever is doing the ultrasound, however good they are at detecting appendicitis, is going to be how good that test is for you as a clinician. Now, I know when I worked in ER that we had one ultrasound tech that was just amazing. He could find anything on ultrasound. So anytime he was the ultrasound tech on call, I'd go with ultrasound first because he was really good at what he did. He could find it. If I knew some of the other techs were on that were not as confident in their skills to detect appendicitis, I might still try it, especially in pediatric patients when you want to avoid CT scans. But in adults, almost exclusively get CTs. You always want to try to limit the amount of radiation to a patient. And like I said, if you have a high clinical suspicion, if the patient read the textbook, some surgeons want to be kind of brought in early and want to make that preoperative diagnosis before the imaging. Complications. Well, perforation can happen in up to 20% of patients. This is definitely more likely if the pain has persisted over 36 hours, like there's a delay in care or a misdiagnosis. Initially, patients tend to have higher fever, diffuse abdominal tenderness, peritoneal findings, sometimes even a mass and marked leukocytosis. If the perforation is localized, sometimes you can actually even get a little abscess in the pelvis, and free perforation leads to a complete suppurative peritonitis with toxicity. And these are pretty significant. They have to go in and clean out the peritoneum because of the leakage of bacteria and infection. So treatment historically is appendectomy, so taking out the appendix, surgical appendectomy. And nowadays, most of the time they're done laparoscopically, especially in uncomplicated cases, which are the vast majority. Prior to surgery, patients should be given broad spectrum antibiotics and should be given at least 30 minutes before surgery. As soon as you make the diagnosis, you start the antibiotics. Up to 80 to 90% of patients with uncomplicated appendicitis are treated with antibiotics and have resolution of signs and symptoms. So it's actually, nowadays, you can actually not do surgery, although still the recommended treatment. You can sometimes recommend that as a conservative management, but I mean, majority of the time, appendectomy is going to be recommended because it tends to recur. What's another interesting thing is, no matter what, even up to 20% of patients who are diagnosed with appendicitis, when you actually get in there to remove the appendix, have a normal appendix, which is interesting to me. Because the illness is potentially life-threatening, taking out the appendix is an acceptable risk even in pregnancy. And if the patient has kind of an perforated appendix and generalized peritonitis, it can be an emergent appendectomy. It's a little bit. There are several different situations when you can delay surgery versus going in emergently. So really, especially with abscess, you might have to do percutaneous drainage where you go in with a needle through the skin. However, that's a little bit too much for our purposes. I will show you an algorithm, though, to help you kind of piece it all together. Mortality rate is actually pretty low. Even with the perforated appendix, mortality rate is, less than 1%. However, it is a high point of litigation. So missed appendicitis is a point of litigation. You can get a lawsuit if you don't catch it the first time. So just be really careful with these type of patients. Don't expect them to have every symptom that we've talked about. It can be tricky to catch in sometimes, so you always have to consider it, especially in the emergency department. So the Alvarado score is used more in adults. Kids is not as accurate, to help you kind of wrap your head around the risk of having appendicitis. So you give 1 point for any of these symptoms here, and 2 for either of these. And that's how you help determine whether you evaluate or you get the CT or the ultrasound, and can kind of follow this along to help you as a clinician kind of work your way through. Because there's a lot of patients that come in with acute abdominal pain, and sometimes you don't want to CT everyone that comes in, so this will kind of help you determine the likelihood of appendicitis in an adult. For pediatric appendicitis, they use something that's called the pediatric appendicitis score, and that helps you kind of quantify for kids whether or not it's required to kind of do an evaluation or not. Now, I know for the hospital that I work at, we have a pediatric surgeon, and whenever she's on call, she doesn't want you to do any CTs. She wants you to call her first. And so you'll get to know wherever you start working what the tendencies are of your surgeons and your attending physicians, because ultimately they're responsible with you, and you'll know what the right thing is to do for these kids. Here's the management for acute appendicitis in adults. This is what I was talking about there are situations where you can do a discharge with antibiotics instead of surgery, and this kind of walks you through that. It also shows you what to do if you have an abscess formation or phlegmon, and how to delay surgery. This is a little more than what I would expect you to know, though, for our test. So a couple pearls to wrap things up. It can be a clinical diagnosis. Don't hang your hat on laboratory findings. Put all the pieces together. Treat the patient, not the lab findings. So if you have a high suspicion, treat the patient. If they have a normal white count, nothing on labs, that doesn't tell you anything. Okay, use your clinical judgment. Just because the patient is not a classic case doesn't mean you shouldn't rule out appendicitis. And, we said that the clinical presentation can vary quite a bit based on the age of the presentation. We want to try to limit radiation as much as possible, especially in the pediatric population. So if you have the opportunity or the means to get an ultrasound instead of a CT, especially in pediatrics, go for it. Don't forget to treat the pain on these patients. It can be quite uncomfortable. And there's kind of this old school thought that if you treat their pain, they'll mask the symptoms they're having. You won't be able to make an accurate diagnosis. That's completely false. I mean, they're still going to hurt even though you give them the medicine. They're not going to be completely pain-free with appendicitis. And like we said, antibiotics nowadays you can sometimes decide to do it, but that's a decision you make between the surgeon and the patient. And my favorite med comic, here's some reminders of what to look for in an acute appendicitis patient. I love that little appendix. He looks so worried. And that is it. We have been talking for 85 minutes. That is a long time. I hope you made it through this lecture, and I hope that you learned a thing or two, and I will see you next time.